endodontic program residency from the University of Pennsylvania. Currently, I'm an adjunct assistant professor at the University of Pennsylvania. And what I'm going to show you, the case I'm going to present, is the management of tooth number 11, tooth with an open apex and apical periodontitis, managed with the revascularization technique. This is a newly introduced technique in clinical practice. It is indicated for this kind of cases and leads to the continuation of the root formation and a normal apical closure. What is new about this technique, about the case I'm going to show you, is that the revascularization technique is used as a retreatment option, meaning as an option to treat a failed previous endodontic treatment. So this is my pre-op X-ray. This is a 14-year-old male patient. The history was that there was a trauma on number 11 at the age of 9. I hope you can see my arrow pointing at the X-ray. What happened is that right after there was a crown fracture exposing the pop at that time, and soon afterwards the tooth was necrosed. So the general dentist went in to do an endodontic access the tooth, did instrumentation of the canal walls, did irrigation with sodium hypochlorite, and then did this pore filling by using 2 combs, and then sealed the access with composite resin. So 5 years later, the patient was referred to me by an oral surgeon because he developed intraoral swelling and pain. And this is what I saw on clinical examination. You can see the discolored tooth. There was intraoral swelling, pain on percussion and palpation, and I decided to remove these 2 cones and do the revascularization technique, hoping to get some dentinal wall thickening and apical closure. So I used number 100 K file, removed the 2 gutta-percha cones, did no instrumentation further, and did a copious irrigation with sodium hypochlorite. And according to the technique that I'm showing, I placed a tri-antibiotic mix in the form of a paste right after that. This is the clinical picture. This is a view from the microscope, 8 times magnification. You can see the tri-antibiotic pastes in the canal. Now the access was sealed with glass ionomer. What we do as a second stage, 15 days later, is that we evaluate whether the clinical symptoms have been resolved, have been eliminated. And once this is confirmed, then I go back in, remove the tri-paste, the tri-antibiotic mix, and I do no instrumentation, but I use a number 20 headstone file to pinch the periapical tissues and cause bleeding to come into the canal. You can see the bleeding in the canal. And once I have bleeding coming up to 3 or 4 millimeters more apically to the CJ, then I want to create a blood clot at this level. So there's a couple of ways to do it. I prefer doing it by placing a collagen membrane, you can see it right here, following an aseptic way, as more aseptically as possible. So once the collagen membrane comes in contact with the blood, it forms a blood clot. You can see it on the upper left image. All these are images from a microscope. Following that, I place MTA. You can see I used gray MTA here. Now I don't use that. I prefer white MTA. A 3 or 4 millimeters thick layer of MTA. And on top of that, I place a moist cotton pellet and seal with glass ionomer. And that's the end of the second visit.
Can I ask a question here, Spiros?
Sure. Yeah.
After you put the collagen in,
yes,
and you stop the blood flow, then you actually remove the collagen.
No. Blood flow comes first in the canal.
Yes.
The collagen membrane, sterile collagen membrane, is placed on top of the blood.
And you leave it there?
And I leave it there. It's fully resolved within 15 days.
And then you put the MTA on.
And then on the same, right afterwards, same session, I placed 3 millimeters of MTA on top of it.
Thank you.
And this is my third visit. Go back in, confirm that the MTA is set, and this is my post-op X-ray actually. Once, this is the layer of the MTA, 3 millimeters layer, and then on top of that I place a thin layer of glass ionomer and seal the axis with composite resin. This is the post-op X-ray. I'm sorry I missed the upper part, the coronal part of the tooth. Now, what we expect to see is two stages. The first stage is the treatment of the apical periodontitis. And you can see here at the 1-year recall, the periapical lesion is healed. We expect healing within 6 months to a year. The second stage is what we want to see is some initiation of the revascularization, meaning some apical closure, dentinal wall thickening, and ideally continuation of the root formation. Now in this case, and like I said, this case, use of this technique as a retreatment option has never been reported before. In this case, I had an apparent apical closure on the X-ray and a minimal dentinal wall thickening. One thing that clinically happens in this technique is the discoloration of the tooth close to the gum margin because of the MTA. And this has to be, if this occurs, it has to be treated with internal bleaching. You can see it right here. For this particular case, I wanted to follow it up for about 3 years. You can see the 3-year evaluation. There is an obvious apical closure, and this is the CBCT views, two views. This is the sagittal view. This is some form of osteoid apical closure. This is the coronal view of the tooth. According to the American Association of Endodontists criteria of success upon evaluation, you can see the clinical symptoms were eliminated, apical periodontitis was resolved. There was some thickening of the root canal walls, but there was no obvious root formation. And probably the reason for that was that the previous general dentist did a hard instrumentation on the dental walls, which is not indicated. That's my opinion on this. Thank you for this, for your attention.
Okay. George, are you still there?
I'm still here. Yeah.
Okay, because your camera is, okay,
There
now
we
it's
go.
okay. Good. Please start your discussion. Virinda is also here. Virinda, hello. Can you hear me?
Yeah, I can hear you.
Wonderful. Hope you could follow the case. I'm switching back to my screen now. Please start your discussion. Probably we need your case still a little bit, Spiros, because I'm sure there are a couple of pictures and descriptions. If you can start your presentation, yes. So please start discuss this great course. Thanks a lot for your efforts, Spiros.
You're welcome. I will be glad to answer any kind of questions that may occur.
Spiros, apical to the root, in this picture, if you take a look at this image on the top left picture, there seems to be a thickening of the bone just apical to the apex.
Yes, that round radio.
Which is, if you see, if I go back to the previous images, excuse me for a second, it was present on the preoperative X-ray as well.
Yes. Do you have any idea what that is? Is that a fractured piece of tooth, or?
I've also seen that on similar cases like this occurring after trauma. Maybe it was some kind of osseous mass.
Calcification, hypercalcification, you mean?
Calcification usually has to do with, you can find it on the tooth, either somewhere in the root structure. But this doesn't look like a root structure, more looks like a bone structure.
Okay.
Well, first of all, I would like to congratulate you, Spiros, for the excellent case. I think it's a great presentation. But I have some doubts. Why, in the first place, you did not choose to make an apexogenesis procedure or apexification procedure? With calcium hydroxide chemically pure.
Apexification has been the standard procedure so far for this kind of cases. However, it has a few disadvantages. First is that with apexification you get apical closure, apical barrier only. You don't get dentinal wall thickening. Second is apexification requires a repeated placement of calcium hydroxide, and this may take sometimes a long time. And according to literature, the more the calcium hydroxide stays in the canal, the more prone to fracture is the tooth.
Okay. And my other question is, in postoperative after your treatment, revascularization would mean also some nervous tissue. And I want to ask you if the patient also had if the patient has some sensitivity to the change of temperature, to coldness or heat, actually.
In this particular case, no pulse sensitivity was reestablished. However, when this technique is used for as a primary treatment, in certain cases reported there is revascularization about 18 months after the treatment.
Okay. And one last question. Sometimes after you have a traumatized teeth, as you can see, the apexes of the right central or the other central and the lateral, they had some root resorption. And according to your treatment, you say there was some apical formation. If you measure the apex of the lateral to the apex of the central, is exactly the same distance as it was a pre-op X-ray. I would say that you get some apical closure, but I would not be that sure if you get some apical formation, actually. If you measure from the apex of the lateral to the apex of the central, from the beginning to the end. Exactly.
You mean, yes, you mean in terms of length for me, root length for me.
In terms of length of the root, exactly.
Yes. Well, in this particular case, as I said, just because it was a retreatment, probably that was the reason that I did not get any root formation. However, the results, if this technique is used for primary treatment, then you, most of the times you get root formation. One thing I have to say is that still this technique, there is still no established protocol for this technique. So the American Association of Endodontists suggests that even if you get dentinal wall thickening and apical formation, apical closure only, no root length formation, then this is also considered as successful.
Okay. I have some other questions, but I don't know if George would like to.
Yeah, Spiros, have you tried material called biodentine from Septodont in a similar situation, and would you?
I have not used it for this particular technique. I've only used it for perforations and iatrogenic errors.
Cyprus? Can you hear me?
Yes, I'm
Can
here.
you hear me? Okay. What about the discoloration we normally get after using premix?
I did not mention my choice of antibiotics. I'm using ciprofloxacin, metronidazole, and amoxicillin. I don't use minocycline, which was the original third antibiotic, just because of the chance, high risk of discoloration?
The limitation in this technique is wherever we are not able to restore the tooth by using simple crowns, this technique is a failure. Because wherever we need post and core type of restorations, we cannot even attempt revascularization.
Absolutely. This technique is only indicated if the tooth is not going to have an intraradicular restoration. Absolutely.
Yeah, and we can also, we cannot guarantee about the dentinal wall thickness in some cases, because it's not always that we will have dentinal thickness all the time. Definitely we can have periapical repair, but we cannot guarantee for the dentinal wall thickness. Am I right?
I agree with that.
Well, we can only guarantee it when there is prospective studies, clinical trials come up. But so far, there's no such thing.
Okay.
Now, on the other hand, like the doctor mentioned, you had, I think, periodontally speaking, it was a total success. I would be a little bit worried, you know, after you get a traumatized tooth, you also, in some cases, you splint it. And sometimes these tooth, the teeth, they tend to get ankylosed. You didn't see any mobility. Do you think maybe in a short term that you will get some ankylosis of the tooth?
That was actually a late, when I saw the patient was already 5 years after the trauma had occurred. So if in this particular, at this time point that I saw the patient, there was no ankylosis. I don't think there will be any ankylosis from now on. As we can see, there is a visible periodontal ligament. But as you said, right after the trauma and for some time after the trauma, especially if the splint is not removed within the correct time frame, ankylosis is very possible. It should happen within 1 year or so.
Okay. May I shortly interrupt? There is a question from Nirjai from India. Nirjai, can you hear me?
Hello?
Hello?
Yeah.
Okay, please raise your question. You already had one, and I'm happy that you jump into the discussion. Welcome.
Yeah, this was regarding the post and core, which already Virendra sir has addressed.
Okay. So your question is already answered?
Yeah, yeah.
Okay.
In case of post and core, you cannot use this technique. That is the drawback of this technique.
Okay. Okay. There is another question from Domagoy. Domagoy, can you hear me?
Hello.
Hello. You have a
Hello.
question.
Good evening, gentlemen. Yeah, I had just one question regarding the disinfection and the healing stimulus. Would you think that the application of ozone as a remedy in this case would be indicated, maybe to help healing?
Domago, I didn't get you said the application of what?
Ozone.
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 For disinfection in this particular case?
Yes, directly into the root canal, and as my experience is, ozone would help stop bleeding, as well as you will have a strong disinfection effect, and as well as I say, from my experience, ozone has a strong healing stimulus to the tissue. So my question is, maybe, I'm not sure if you are able to use ozone, but what do you think? Would such a case or such lesion would be indicated for ozone treatment?
That's a very good question, actually. I don't personally use ozone as a means of disinfection, but any kind of disinfection that you may use, my concern is that this should not be too much cytotoxic on the vital cells that are present at the apical part, very apical part of the tooth that goes to the periapical tissues, which is the key concept for using this technique.
Thank you.
For example, a high concentration of sodium hypochlorite is highly cytotoxic to the stem cells that are present.
That is the reason why I asked, because higher concentrations of ozone could even have a stronger healing for the tooth. You even have to reach higher concentrations to have a healing effect because of the lipid peroxidation products, which are important for this healing and prolonged effect of ozone. That's why I asked, because in this case I think ozone wouldn't be cytotoxic, but would even be a help in healing process.
Yes, of course.
Thank you for
If it, yeah, thank you. I mean, it could be used, it could be tried. It's still experimental stage.
Yeah, okay. Great, thank you.
I have another question here. Nico, if you may. Do you ever remove the MTA from the tooth?
Only on situations, only on a case that this may not work. If I don't have apical closure, or if I get clinical symptoms again, then I inform the patient, or actually I inform the parents beforehand that if this technique fails, then I'll have to go back in and remove everything.
Okay. I have another question from Mohammed Al-Sheri. Mohammed, can you hear me? Mohammed, do you have a microphone? I entitle you to speak. Obviously he does not have, but I try to read his question. I need it a little bit bigger. Where is it? His question? Okay, here. Okay, there are a lot of questions. I have to make it larger. Okay. Which such thin root walls do you consider this as a long-term treatment?
Sorry, Nico, could you read that?
Okay, with such thin root walls, do you consider this as a long-term treatment?
Yes, I would consider this as a long-term treatment, as long as no clinical symptoms should rise again.
Okay.
I have to remind you, I have to point out that if I did use apexification, there would be no more dentinal wall thickening.
Okay. Then there are another two questions from Mohammed, but I first do something from the island, which is Great Britain, of course, Mark Cruncho. First of all, he says, great case. I try to entitle him to speak. Mark, can you hear me?
You bet. I can hear you. Can you hear me okay?
Raise your question by yourself. I can't read it. You know I'm a patient, and I hate that.
That's a great case. I love it. The only issue I have is regarding the profuse irrigation with the hypochlorite, which, as you say, is cytotoxic. Are you not concerned with periapical extrusion with such a big wide apex like this? I mean, have you encountered problems in similar cases?
That's a very important concern, and the way to prevent this is either by using the side-ended needles, or even better, I use Endovac.
So you're being very careful just not to use force as you're irrigating through the apex.
I would say as a safe rule, maybe if you don't have a side-ended needle and you want to irrigate then you should stay at least 2 or 3 millimeters away from the radiographic apex.
Okay, and if I may just ask one further question. In regards to the bacteria that have already got into the dentinal tubules from the interior of the root canal, we know that we're going to get 300 microns kill with hypochlorite, but there's going to be some smear layer there, which the hypochlorite's not going to be removed. Do you just use hypochlorite, or are you using other irrigants like EDTA or anything like that to remove the smear layer, or do you not think it makes any difference?
Actually, the key important thing, in my opinion, is what are you going to use as an irrigant after removal of the triantibiotic paste. So I used to use sodium hypochlorite, but then I read on some articles that EDTA can be less cytotoxic to cells, and furthermore, it can remove any kind of smear layer. Although I said we don't do it instrumentation in this technique, so smear layer is minimal.
That's absolutely great. Thanks, Spiros.
You're welcome.
Spiros, question. When you were dealing with this patient's parents, what do you tell them about the prognosis for this tooth? How long can they expect it to last? And obviously, eventually, you'll be able to replace it with an implant, but what is the current status of it?
I give them a time frame. So if there is no, like I said, the first stage that we want to see is the treatment of apical periodontitis. If this should not happen within 1 year, then I either switch to apexification, or then we consider extracting the tooth.
How about also apicectomy and retrograde obturation, Spiros, as an option treatment?
That could be also within the treatment options. But then again, in this kind of cases, that's the last result, I would say, because we're treating with pedo patients and they're still development. So any kind of bone surgery has to be considered.
And my last question, here you can see with the CBCT at the sagittal view, there is actually a body object. It's a round object. Wouldn't you consider to be an odontoma?
To be, excuse me,
odontoma in the CBT. You can see it's a round thing. It looks great, the shape with the CBT. And actually, if you don't see this round body, you could see that the apex is still open. So I don't know if this could be an odontoma.
Could be an odontoma or any bone-like structure. My thought is that probably has to do something with the trauma, because in similar cases, central incisors after trauma, I have seen this odontoma or osteoid structure again.
Well, really, I want to congratulate you. It was a great case, and we can wait to get it published at the Journal of the Academy of Endodontics, American Association.
I will be honored. Thank you so much, mate.
Congratulations.
Congratulations.
Cyprus.
Okay.
Cyprus.
Hello?
Hi, Nico. And one more question from Cyprus.
Yes, sure. Come on.
Yeah, Cyprus, I would like to add something here. We were talking about the ozone. As far as my experience is concerned, the ozone definitely helps in reducing the anaerobes from the root canal, especially when you have some particular kind of anaerobic odor. You feel some kind of smell. That is because of some particular bacteria. That is eliminated to a greater extent. The only problem is when we use ozone, and because the ozone is circulated within 3 mm of the apex. So post-operatively, sometimes the patient feels a little sensitivity and post-endodontic discomfort. That is the only problem which we encounter when we do ozone therapy while doing endodontic treatment. Otherwise, it is a great thing because it can absolutely remove the bacteria and make the canal sterile. That's an excellent. The only thing is these are the two problems because the patient feels sometimes discomfort. That is a problem.
And you're talking about regular endodontic treatment, permanently closed apex.
Yeah. Only one unit, like Ozotop, one unit can help you for multiple purposes. Like for implant surgery, it can be used. For oral surgery, it can be used. For endodontic, it can be used. Even for the treatment of caries, it can be used. Because before you place your pit and fissures, if you use the ozone on the pits and fissures, you can sterile the deepest portion of the pits and fissures so that you don't have the bacteria in the deep portions of the pits and fissures. If you place your pit and fissures sealants, those give much better results than if we do it alone without, using ozone. So it has multiple uses.
Yeah. Thank you so much.
Okay, fantastic. I guess we should take Spiros out of the fireplace now, from the grill station.
Great case. Oh,
I enjoyed it.
Congratulations. Great case.
I guess it was a very great case, and I personally am pretty happy to see you guys discussing those very important cases on a very good level. I think it's compelling, and it also encourages me to set up our roundtables more often. Now I would like to switch to George Freedman. He is already in the start box. I switch to your screen now, George, and you please present your case. Make a presenter. Yes.
Show my screen.
Yes, show your screen, please.
Show my screen.
Yeah, it is
Show my
shown.
screen. I can't see it.
But I can see it.
You can see it. Okay.
Yeah, you don't have to see it. We see it.
So you see, you see my presentation on the entire screen?
Yes.
Or?
Yes.
All right. So I'm going to be talking about something that seems to be impossible. No cement, no stress implants. This is something that happened to me because I ran into a problem that I was, according to instructions, I was cementing my implants, and my implant crowns already buttoned, and then sometimes the porcelain fractured because of the patient biting into something, and sometimes the screw, the button screw, loosened. And then, of course, it's a temporary cement, so it's easy to take off the crown, right? Well, not so right. In fact, that temporary cement becomes hard very quickly, and it doesn't work out very well. And you end up redoing the crown, sometimes redoing the abutment, and if it's too soon after the time that you place the implant in the first place, then it becomes your expense. Patient gets the service, but you pay twice for it and you lose money. So that is the preamble of why I'm going to do things the way I do them here. It's a slight differentiation of the process that we use. First question is, why implants? Well, in this case, you can see for tooth number 12, it's a failed endodontic treatment, or possibly no endodontic treatment in that tooth. Hard to tell on the x-ray that you see. The post failed, the tooth fractured, and the entire crown was gone. There's one added complication. The patient lives about 1,000 kilometers from my practice, but her whole family has been coming to me on a regular basis. So let's see what we can look at. Well, we have adequate bone for the implant. This is really not a problem. The implant was placed, and an aesthetic healing abutment was placed as well. Why an aesthetic healing abutment? Because it's going to look better. A metal healing abutment is not going to be possible to restore in a fashion where the color doesn't show through the provisional restoration. In this case, because it's an anterior tooth, and I don't believe in doing a partial denture provisional, we put in provisional restoration, that is tooth color, made from regular provisional material, and this is simply kept out of occlusion, so there is no force on it. The patient is instructed not to bite down on it, not to use it in function. And we can make a relatively good provisional, as you see on the right over here. The thing that I've always tried to do is to have the lab technician make the provisional, and then I just reline it. Ultimately, this never works out, so now I've given that up, and I just do it freehand. It shouldn't be a problem. Make sure you lubricate the implant abutment over here, or the provisional abutment, so that the composite doesn't stick to it. The important part is that the gingiva not be irritated by the composite or the material that you're using for the provisional. In this case, this is a rubberized polyurethane, so it's less irritating than a bisacryl, but even so, there's going to be some irritation. So if you take a look at the close-up over here, I'm afraid it's not a great resolution, but you see the provisional ends away from the gingiva, which means we're not going to have any irritation. This is the time of placement. The implant was placed the very same day. The patient came over to my practice immediately after, and I did the provisional, sent her on her way. She was flying out shortly thereafter. So let's see how the tissue responds. After osseointegration, we have a situation that looks a little bit different. Why doesn't it show? Next. Here we go. The bone is healthy. You can see the provisional over here. The margins of the provisional are quite good. And notice the tissue over here around the provisional. Tissue has blended in very nicely because we've kept the provisional material away from the tissue. And that applies to the provisional material and the provisional cement. The osseointegration looks very nice over here, and everything is set to go. The healthy gingiva is paramount. Here we see it from far away. As we get closer, we can see the gingiva that is healthier. In a close-up over here, you can see how nicely that's responded. That is not because I'm so wonderful with the provisional material, making provisionals, cementing provisionals. It's simply because the provisional margin is about 1 millimeter away from the gingiva, and because of that, it does not irritate. So if you don't get groups that fight each other, like the gingiva and the provisional materials and cements together, they won't fight. This is cemented with a temporary cement, so it should be easy to take off, correct? Well, no, it's not. So what happens is I have to cut it off. At this point, if you realize that's going to be the case, it's good to have an impression before you take it off, before you cut it off, so you can easily recreate a new provisional for the day or two that the patient is going to be without it. Anyways, we take that off. Here is the aesthetic provisional abutment, and you can see the screw that's holding it. We take it out. What does the tissue and what does the implant look like? Tissue looks very nice. This is what we were hoping for. It's just going to hide the metal portion of the abutment subgingivally a little bit, not completely, but a little bit. And this is what an ideal shape for an implant restoration. So that's the next thing we're going to do. We'll take the implant, or the impression of the transfer abutment, transfer coping, send it to the lab, take a shape. In this case, we have the lab, or the patient goes to the lab and has custom shading, and then I get back the implant assembly. And here is the way you see it from the buccal, and here's the way you see it for contour from the occlusal. And now you'll see something that you may have not seen before. This is the difference that I use, because remember, I don't want to use cement. This is going to be a cement-free restoration. So I'm going to have a horizontal set screw. An occlusal set screw would not work over here, because the occlusal set screw would come out roughly over here, and the patient might object to that from an aesthetic point of view. Although it would be different, it might still be objectionable. So what we do is we put a horizontal set screw from the lingual, totally accessible. This means that I can take this crown off if it loosens, if the cement, if the ceramic fractures. I can take this off 5, 10, 15 seconds, do whatever I have to, put it back in. In fact, that happened with a patient yesterday in my practice. In another case, patient came in, the implant screw was loosened. I took it off, cleaned it out, screwed it back in. Whole procedure was less than 5 minutes. A lot less stressful. So let's see it in the mouth. Here's what it looks like in the mouth. Now, this is the set screw hole in the abutment. This is going to be accessed not from the buccal, obviously. It's going to be accessed from the lingual. In order to make the lingual accessible, we cut it back. I don't cut it back. The lab takes this, takes the regular abutment, just shaves it down to where it needs to be. Using a standard abutment is much less expensive than using a custom abutment. Very simple. It's cheaper for the dentist, cheaper for the patient. So now I'm going to slide on the crown, and you can see the crown over here is fitting over. When I have a cemented crown, especially one that goes far subgingivally, it's very hard to tell if the crown has fitted down all the way. The only way I can tell is by looking at the occlusal margins and trying to guess if that's correct. On the other hand, here I have a perfect frame of reference. If you take a look over here, I've got the set screw hole. If my set screw hole fits in directly, then I'm exactly at the right spot. So that's very important. It, again, takes the stress out of my practice. I don't have to worry about it, and I don't have to use cement. I take the set screw driver, which looks like this. Here's the set screw, very inexpensive, costs about $1 or $2. Here's the set screw driver. Place it in. The only thing you have to worry about is to make sure you're going to have enough room to be able to turn this, usually with your fingers. So on a lower arch, very often you want to do it on the buccal, not on the lingual, because the arch shape might not leave you enough room to put this driver in and to actually turn it. So we put in the set screw and we tighten it. We've checked the occlusion over here. Everything is fine. Of course everything is fine because there's only one position that this crown can go on. The ideal position that it's being manufactured to in the lab, and that's guaranteed by the set screw. Because the set screw is almost flush with the surface, I don't cover it with anything. I simply leave it like that. Patient will remove any food debris from there with their toothbrushing. If any food debris does get stuck in here, the brush will take it out, and after all, food debris cannot irritate metal, because that's what this is. Let's take a look at the buccal. When the patient smiles, there is a little bit of hint of the metal implant over here, and that's something that we're trying to get around using ceramic implants and ceramic abutments, but those are still not at the ideal stage yet. But you can see the color has blended in very nicely with the adjacent teeth, and here we'll take a close-up to show you the gingival relationship and to show the tissue, soft tissue, and hard tissue relationships of this particular implant. Bone crown, no cement, no stress, easy to do implant. Thank you. Any questions?
Hi, George.
Yeah.
George, I think you made us speechless. Actually, this is an excellent case you have done. I must congratulate for this presentation. Definitely, I should congratulate. I think all must agree with that.
Thank you very much.
Yeah.
It's in the spirit of sharing, because this is an idea that I think makes life easier for me, and I want to share it with my colleagues.
That's wonderful. That's wonderful.
Very nice. George, excellent case. Congratulations. I have one question. Before extracting the tooth, wouldn't you consider to do, me as an orthodontist, this is why I'm questioning, orthodontic eruption, force extrusion, to gain more bone thickness for the implant? Or how, I wonder how the implant was positioned. You put the implant right away after the extraction?
Well, what happened here if you take a look at the X-ray over here, you can see that there was a fracture right over here.
Okay.
At this level. So even if we've been able to get some orthodontic eruption, redo the endodontics, it still leaves us with a root that's about 8-9 millimeters long. I'm not sure that that would be adequate. The other complicating factor is that the patient comes from not a major city, but from a small area where access to specialists is limited. And she has to have treatment as compressed as possible in a large center such as Toronto when she arranges trips to this location.
Okay, thanks. It sounds great. I was wondering about to do the whole extrusion of the root to gain good bone thickness, not only to put a post on the ground, but it actually came out very nice.
Yeah, and now the question is, should we have grafted on the buccal to create a little bit more bone? Probably. Okay. But again, that would have meant an extra 2 trips for the patient, and it would have added to the cost tremendously.
And how about the papilla, the interproximal papilla? Do you think there would be a way to gain a little bit more to fill up those small black spots at the end? I mean, the crown looks great, looks amazing. There you go, just in the interproximal. Do you think there could be any other thing to gain some more papilla? Right.
This is immediately after I placed it, and I would like to think, I haven't seen a patient since I placed it, I would like to think that the papilla will grow into those spaces because there's nothing to prevent them and everything to encourage them. There's no irritating cement, there's just ceramic and titanium in this area interproximally, a natural tooth here and here. Okay. So could we do that? I think it's an excellent idea, and it's something that I think on revisiting with the periodontist who did the actual implant, the surgical implant procedure, is something that I'm going to bring up and I'm going to make notes about it as we speak.
Well, congratulations.
Can I shortly entitle an attendee on this great case? It is Bahman from Iran. Bahman, can you hear me? Bahman? Hello? Bahman? Obviously, can you hear me? Okay, then I raise the question from Bahman Derakshan from Iran. Thank you for your nice job. But did you consider to retreat the tooth and make a forced eruption before substituting with implant?
This was essentially the same question that Maurizio asked, and the problem was there was a fracture, a root fracture, about 2 or 3 millimeters apical to the bone crest. Forcing the eruption of the tooth would have been a good idea, but would have left us with a root that was only about 8 millimeters long, which would not have been enough to counteract the torque of the crown that was placed on top of it afterwards.
Okay. Virinda, do you have some ideas to this case?
Yeah, sometimes whenever some root fracture is there, we try putting up intra-endodontic posts. That is one thing we can do. Like after doing root canal treatment of the apical third, right, and obturating the apical third, we can put a post inside and we can keep the tooth as such. We don't need to do a fraction. But sometimes that is not a very successful treatment for a very longer time. So there may be some kind of either external resorption or some kind of lateral periodontal abscess at the fracture site. But yes, one can try for, suppose sometimes the patient doesn't afford implants, right? So sometimes it's very expensive for the patient. So in those cases, we can try for putting up a post inside the canal. so that those fragments, the fracture fragments are approximated. At least for sometimes, for few years, it can really work.
One consideration we have is always the benefit of the patient. That's the major consideration. There's the health benefit, and there's the cost to the patient as well. Within our environment in Canada, to have a surgical procedure, a periodontal procedure for the exposure of the fracture, an re-endodontic treatment, a new post, and the crown would have cost approximately 30 to 40% more than the implant and the crown did in the first place. So even from a cost perspective, this did not make sense. But certainly from a long-term treatment perspective, as you mentioned, doing an intra-radicular post could work for a few years, but will likely cause problems at some point. This is a procedure that we can expect to last for many years, possibly a lifetime.
Right, that's right.
Do I make a point on that? First of all, I would like to congratulate you, George, on this excellent case and excellent documentation. And I would like to first make a point concerning orthodontic eruption or forced orthodontic eruption in case of a fracture, and probably Mauricio can correct me on that, that if you do it, there's a high risk post-operatively of the root going back in, like a small amount of re-intrusion of the root as a result, sometime after the eruption. And if you're going to place a post and a crown on this tooth, either it has to have a tight interproximal contact with the adjacent teeth, or you have to splint it, make two crowns joined together with another one, so you're going to have to sacrifice one of the adjacent teeth, as far as I know, concerning eruption. And the second thing, I have two questions for George, is would you do any modification in this technique when you have a patient with periodontal disease, especially an aggressive form, meaning a vertical loss of the bone ridge, or an oblique loss of the bone ridge, or if you have a patient who's a bruxism?
Okay, let's consider those two questions separately, because they're really two issues. If you have a patient who is an uncontrolled periodontic patient, putting an implant in is a risk, absolutely. But it's probably the lesser of all risks. And ultimately, an implant is easier to maintain than natural teeth and deep pockets. Again, ultimately, if the patient is that severe a periodontal risk, they're going to end up losing most of their teeth, and they will eventually wear a denture borne by implants. If we put in an implant at this stage, where we still have some bone, the implant will actually maintain the bone height better than natural teeth will for periodontally compromised patients. So while we have to do everything we can to get that periodontally compromised patient, and the periodontally compromised patient is very often not diseased. The disease exists here and here. They don't brush and floss, and they don't use their hands to clean their teeth. It's not a physical disease, it's a mental and manual disease. So if we cannot convert our patients, we have to think 10, 20 years ahead and to see where are they going to be best served when they finally have taken such good care of their teeth that they lose all of them. So I don't like to deal with periodontally compromised patients. We don't get good results for them or for you, but sometimes we have to face them. So that's the one question, or the one suggestion that I have there. For a bruxer, bruxers are a problem. They destroy their dentition. How can we solve the problem over here? Well, there are two ways. Ideally, you build up, bruxers have lost posterior vertical dimension, and that's why they're touching their anteriors. If you can build up the posterior vertical dimension of occlusion with comprehensive maxillary mandibular crowns, ceramic against ceramic, or any one of those new materials, the zirconia and so on, which are indicated for this, that will help to stop it and keep the anterior vertical dimension open so you can put in a crown reasonably. You also want to use a night guard for these patients, and you also want to keep the anterior out of occlusion. So you make sure that in every single occlusal extension, whether it's anterior or lateral, they cannot touch that anterior tooth, because if they do, they will break it. But the solution, aside from avoidance of contact on the anterior, is opening up the posterior vertical dimension so that the anteriors cannot contact. We have a lot of patients who are bruxers. We try to eliminate their stress. That doesn't work. So we have to do what we can to keep them with healthy dentition for as long as possible.
Okay, if you let me, I agree totally with you with your two answers for Spiro's question. And talking about orthodontic force extrusion or eruption, if you want to keep that root of the tooth, like you mentioned, Spiros, when you do some extrusion, there's also going to be some residue. So like you mentioned, you have to split. But I was talking about that, orthodontic force eruption. Actually, if you have a periodontal compromised patient that has some vertical loss also of bone, with a completely eruption or extrusion of the root, we are going to create some bone for the implant. So in orthodontics, actually, if we have only 1/3 of the root, and we do a root canal and you put like a post with a hook, we can traction that apex all the way to the gingival third, and we can create some nice bone level for the implant. And I was talking, of course, I agree with George that tooth should be extracted. The only thing I was mentioning, if they were considering to do the whole root force extrusion to create bone for the implant. So, I mean, this is a great case, but talking about periodontal compromised patient, with orthodontics, we can make a whole bone from the apex all the way to the gingival third.
Yeah, you were talking actually exactly like extrusion to the point of extraction.
Exactly, the whole root all the way,
Exactly.
not keeping it.
So as to bring bone together. And,
exactly.
If I'm correct in that, you also have to cut the periodontal ligaments every 15 or 20 days or something.
Exactly, exactly, because the periodontal ligaments will always also try to do some residue. Periodontal ligaments, transseptal fibers are our worst enemies in orthodontics, because they always tend to, for residue, for when you have rotations and any movement you do in orthodontics, you will get some kind of residue from them. So I hope we answered your questions. And just the last thing, talking at the final case, me looking at the point of orthodontics, the patient had a kind of an open bite tendency. So at the end, I will put full braces and just finish them.
Thank you.